Good day. I'm Dr. Martin Bergman here at Maui at the Rheumatology Winter Clinical Symposium. I had the opportunity to give a talk the other day on interpretation of clinical data from clinical trials. Whenever we read a journal and we look at the clinical trials, we have to recognize that what they're trying to do and what we'd like to see is what's cause and effect. Drug A protected us from having something. Drug B is better than drug A. Drug C is better than placebo. We want some cause and effect, and that's the ideal situation, but it doesn't always occur. Sometimes we have what's known as effect and cause. Think of the old studies that looked at prednisone causing pancreatitis. It was felt that if you gave prednisone to somebody, pancreatitis ensued. But what they didn't know at the time, this was back in the 80s, is that most of those people who got prednisone had active lupus, and it wasn't recognized that lupus had pancreatitis as a manifestation. So the patients had active lupus, were given prednisone, they had pancreatitis, and it was the prednisone that caused it, but actually no, it was the lupus that was the reason they were getting the prednisone, thus effect and cause. There's also randomness, just sometimes things happen by accidents. A lot of studies have shown in some cases where the drug was given, and in that particular drug group, a side effect occurred, and it was more common in the study group than it was in placebo. Think of cancer in abatacept. When abatacept was first released, there was an increased rate of lung cancer. It was only after years that they found out it didn't really happen other than by chance. It was just bad luck that the patients who were in the abatacept arm had more lung cancer. It never panned out. But it's still in the package label, so this is a very important thing. We can look for these causes, but there are other causes that we have to think about, and those are biases and confounding in the study. There are lots of different reasons why this occurs, and it occurs both in observational studies from large cohorts and in double-blind placebo-controlled. Neither study, neither type is free from the possibility of bias. And what it comes down to is, how did we pick the patients to go into the clinical trial, be it observational or a randomized double-blind placebo control? Was there something about them that made them more likely to go into the study? Were they sicker? So maybe they didn't get a particular drug and were more likely to get a second drug. Was there something about their particular characteristics? One of my favorite studies is studies that have looked at marathon runners and osteoarthritis. There have been many studies that have shown marathon runners are less likely than the general public to get osteoarthritis. The implication, of course, is that if you run marathons, you're not going to get osteoarthritis. And that might be true. There might be something about running that is very healthy for you. On the other hand, maybe it's that people who have osteoarthritis stop running. So the people who continue to run marathons don't have osteoarthritis. This would be called a channeling bias. There are other times where you have preferences for drug, but maybe by the physician. So I may like an IV drug more than another doctor. So if we're looking at situations where we're comparing persistence of one drug versus another, I may like this particular drug and I may hold them on a drug longer than the ones I like than ones I don't like. So when we look at persistence, that could bias it. One of my pet peeves, if you will, about biases is missing data. Missing data comes in a lot of forms. The long-term continuation study is one of the places that drive me crazy, and we see a lot of missing data where you simply don't see what happened to the patients. But we also see this in very good or so-called well-designed study where there's a lot of data that is missing, we simply don't see it. Multiple other types of biases exist. I don't have the time, but you can go to Rheumnow to look at more detail. But things that we can do to control for the bias is things like matching, where we take large groups of other populations and put them and try to match them with the group. We can try regressions, where we control for certain variables and try to make it so that we have a better understanding. More commonly now, we're seeing something called propensity score. Propensity score is the hot thing, and it's a way of trying to control bias. What they do, think of this as a mega regression. What they try to do is think of every possible confounding variable that could be out there. They can look at 60, 70, 100 different variables that they think are confounding, and then through mathematical modeling, they can try to say, okay, based on this group of confounders, this particular group was more likely to get drug A than drug B, so we're going to adjust the results by that kind of bias toward one drug or another. It's an improvement, but it is not perfect. And not every bias can be kept in mind. One of the ones I always think about, again, was the same thing I alluded to. Physician choice is hard to control for. So if I'm getting paid, for example, to give a particular drug, I'm making money on it, I may tend to use that more than another drug. Keep in mind that these biases exist. It's important for the authors and it's important for the journals to look into the potential bias when they review and print a journal article. But as the consumer of information, it's also it's essential that you start learning to recognize and look for biases and not just take the conclusions and the p-value at the end of the article as being face value. Be a critical reader and learn how to read journals properly and get the true benefit of the articles you're reading. So thank you, and hope you have a wonderful day.